Hey everyone, and welcome. If you're a future nurse, you are absolutely going to encounter clients with bipolar disorder. So, understanding this condition isn't just about acing your exams. It's about providing safe, top-notch care. In this study guide, we're going to break down everything you need to know to feel confident in both the classroom and the clinic.
All right, so here's our game plan. We've structured this to flow just like the nursing process. We're going to start with the fundamentals, then move into assessment, planning, and of course, the medications. Then, at the very end, we'll pull it all together with a case study to really test your skills.
First things first, let's get the basics down. Before we can even think about assessing a client or planning their care, we have to have a rock-solid grasp on what bipolar disorders actually are and what they look like.
Now, this definition is so key. Bipolar disorder isn't just about the highs of mania. It's about that intense swing back and forth between two opposite poles, mania and depression. And it's also super important to remember that in between these episodes, many clients can and do have periods of totally normal functioning.
Okay, this is where a lot of students get tripped up, so let's clear it up right now. The biggest difference between bipolar 1 and bipolar 2 is just how high the high is. Bipolar 1 has at least one full-blown manic episode. We're talking severe, often needs hospitalization. Bipolar 2, on the other hand, has what's called hypomania, which is a less intense version. So an easy way to remember this is bipolar 1 is the one with the most extreme mania.
You've absolutely got to get these three phases down because your job as a nurse changes completely depending on which phase your client is in. During that acute phase, it's all about safety and just getting the mania under control. But once they're stable, your role shifts big time to education and helping them prevent a relapse.
Okay, let's switch gears to assessment. This is where you, as the nurse, really start to put the puzzle pieces together. Recognizing the signs of mania versus depression is one of your most critical skills. And wow, this slide just lays it all out, right? The two complete extremes. So think about an NCLEX question. If you see a client who's giving away their car, talking a mile a minute and hasn't slept in 3 days, your brain should be screaming mania. But if you see a client with zero energy, that's inertia, and they've lost interest in everything that used to love, anhedonia, you're looking at the depressive side.
Okay, listen up, because this is a huge NCLEX topic. You have to teach your clients about these triggers. It's so important for them to understand that something as simple as not sleeping well for a couple of nights can be a massive warning sign that a manic episode is coming. This is how we empower them to manage their own health.
So, we've got our assessment down, we know what we're looking for, now what do we do? When a client is in an acute manic episode, your number one, top of the list, non-negotiable priority is safety, always.
This is basically your playbook for acute mania. A huge strategy is decreasing stimulation. A quiet, calm environment can work wonders. And don't forget their physical needs. Clients in a manic state are constantly moving. They're burning a crazy amount of calories and are at risk for total physical exhaustion. That's why we give them high-calorie, portable foods they can eat on the go, because they're definitely not going to sit down for a 3-course meal.
I love this quote because it's pretty much the secret sauce to therapeutic communication during mania. Their world is spinning out of control, so you need to be their calm anchor. Be direct, keep it simple, and do not get into an argument. Your calm, matter-of-fact presence is your most powerful tool.
All right, time to dive into the meds. And we've got to start with the big one, the gold standard for treating bipolar disorder, lithium. You'll absolutely be tested on this, so let's make sure you've got it down cold.
Okay, if you're going to write anything down today, write this down. Get out your flashcards. 0.6 to 1.2. Say it with me, 0.6 to 1.2. This is the therapeutic range for lithium, and it is incredibly narrow. That means there's a razor-thin line between a dose that helps and a dose that's toxic, which is exactly why the NCLEX loves to ask about it.
This table is brilliant because it shows you exactly how things go wrong, step by step. Look here, below 1.5, you might see things like fine hand tremors. That's kind of expected. But the second that level creeps up past 1.5, the tremors become coarse, and you start seeing confusion. That is a massive red flag. Distinguishing between fine tremors and coarse tremors is one of the most important things you'll do.
Here is another huge NCLEX alert. You have to understand the relationship between sodium and lithium. Think of them on a seesaw. When sodium goes down, maybe from dehydration or a stomach bug, lithium goes up into the toxic range. This is why you have to be so careful if your client on lithium is also taking a diuretic, like furosemide, because that drug makes you lose sodium and could cause a dangerous interaction.
So what happens when a client can't take lithium? Well, that's where these guys come in, the mood-stabilizing anti-epileptic drugs. Each one has its own set of really important nursing considerations, so let's break them down.
Okay, I've got a little memory trick for you that's going to save you on your exam. Just remember, carbamazepine can crush your CBC. That'll help you remember that it can cause major blood problems, or blood dyscrasia. That means you need to watch their complete blood count and teach them to report any signs of infection, like a sore throat or unusual bruising.
You have to know these. These are the life-threatening ones. For valproate, think liver. It can be toxic to the liver, so you're always going to monitor liver function tests. For lamotrigine, the big scary one is Stevens-Johnson syndrome. It's a super serious rash. That's why you teach your client that any rash, no matter how small, needs to be reported immediately.
All right, pop quiz time. Let's see if you were paying attention. A client is starting on valproate. What labs are we going to monitor? Lock in your answer? Ready? If you picked A, you are absolutely correct. Because valproate carries that risk of hepatotoxicity, or liver damage, we have to monitor their liver function tests.
Okay, deep breath. We have covered a ton of ground. We've talked basics, assessment, interventions, and meds. Now for the fun part. Let's put it all together and apply this knowledge to a real-world scenario. This is where we test your clinical judgment.
This right here is exactly what you'll be teaching your clients and their families, especially once they're out of that acute phase. The name of the game is relapse prevention. It all comes down to having a good routine, taking meds, and knowing those early warning signs we talked about.
All right, let's meet our client. We have a 34-year-old with bipolar 1. He comes to the clinic and his lithium level is 0.8. So, first question, is that good or bad? It's good. It's right in that sweet spot, that therapeutic range. So, everything's fine, right?
And here's the plot twist. He's had a stomach bug for 3 days. That means nausea, vomiting, diarrhea. He's losing fluids and he's losing sodium. And what did we learn about that seesaw? When sodium drops, lithium goes up. And now look at his symptoms: confusion, unsteadiness, and shaking badly. Those aren't fine tremors, are they? No way. These are the classic screaming signs of lithium toxicity.
This is it. This is that clinical judgment moment the NCLEX is all about. You've recognized the cues, you've analyzed the problem, you're thinking this is lithium toxicity. So what's your next move? What is your priority action? The one thing you have to do right now to keep this client safe. Think about it, because your next move could literally save their life.